Fantastic. Okay, so Ceftriaxone in emergencies. So the question that I'd like to pose to everybody is whether there's a need for a standardized approach here. The context to all of this is really a lot of pediatric simulation. So I'm sure that a lot of you know from EM and PEDS backgrounds that invariably when you have a pediatric simulation day, you will have a pediatric sepsis or a pediatric status epilepticus scenario of some sort or another. And they kind of follow a bit of a pattern. So you sort of start off with a smallish child, possibly has had a bit of a fever, and they present obtunded. And in this sort of example, we've got a child with an airway that's self-maintained, who is saturating okay in air with no focal signs, but is tachycardic, possibly slightly hypotensive with a prolonged refill time, but otherwise a sort of normal cardiac examination. And they appear a little bit drowsy and obtunded and only respond to voice or pain. They're febrile, they've got a normal sugar and no rash. And being the fantastic clinicians that we all are, we say, well, this could be sepsis, or it could be meningitis, or it could be encephalitis. And at the back of our minds, we keep in mind some obscure things like myocarditis and toxins and surgical shock. And typically what happens is that people try for a line, and depending on how nice the simulationists are, you might get a line, you might not. But often there's sort of some difficulty with IV access, and you get a single line and you start giving some fluids and then plan to give some antibiotics. In London and the east of England, generally the first line antibiotic is Ceftriaxone, and I'm aware that in other regions it could be a different cephalosporin, but usually for these sorts of children, it's Ceftriaxone in our regions. So far so good. And then often from one of the nurses, there'll be this question of how fast would you like to give the antibiotic, and what dose and what rate. And that's where in our experience in these scenarios, we were finding that there was a fair amount of variation in response, and particularly to do with the rate at which Ceftriaxone was being delivered. So a few of us sort of put our heads together and had a think about this and tried to consider whether there's an actual real problem here or not. And we had a look at a little bit of the literature around this. And it's evident from the literature that delivering sepsis bundles in a timely manner is really, really important. So there's lots of adult literature around this, and a fair amount of pediatric literature. The most sort of prominent study is one from 2018 in JAMA, which showed that giving a bundle of care, including taking off some blood cultures, delivering some fluids, and giving some antibiotics within an hour seemed to reduce mortality across New York State quite significantly, so mortality and morbidity. And there have been other studies which show that a lack of IV access in these sorts of scenarios is common in real life, and is probably the biggest barrier to delivery of bundles of care. So this example is a study that looked at, it was a big tertiary center, and they had about, I think, sort of 80 to 100 cases of sepsis or septic shock over the course of a couple of years. And they looked at sort of how effectively they were delivering bundles of care and what the main reasons were, what main barriers were to not delivering the sort of, the PALS guidelines or American Critical Care Society guidelines. And the top thing was lack of IV access, alongside not recognizing shock or not having enough team members as sort of secondary and tertiary factors. So it sort of seemed to us that there possibly was a real problem here, and we kind of wanted to look into that a bit further. And we felt that if we could iron out these issues around variation of antibiotics in terms of rate, that it might be helpful in terms of kind of offering resuscitation benefits. But also these variations in doses might be leading to subtherapeutic dosing or unsafe dosing of antibiotics in some instances. So what we set out to do was essentially a service evaluation across 2 regions and to describe practice. So the context I've already set out, and we tried to understand whether IV access impacted on timely resuscitation as far as clinicians were concerned in the regions. whether or not high dose ceftriaxone is the most commonly used antibiotic in critically unwell children, which we suspected it was, and what the rate is that ceftriaxone is being given at. And the way that we did that was essentially to send out a survey to emergency medicine clinicians, pediatric colleagues and pediatric pharmacy colleagues across all of the 50 acute pediatric centres in London and east of England. And we provided them with a short online survey asking them about predominant practice and local guidance, having set out a sort of an example scenario of a 2-year-old in septic shock where IV access is a difficulty potentially. And this is what we found. So we got a response rate of about 44%, which isn't fantastic, but isn't too bad. And sort of a broad range of respondents. So about a third of them were emergency medicine clinicians, just over a third were pediatricians, and then we had a third who were pharmacists. And just to highlight that the pharmacists had there were skip questions built into the questionnaire. So really for the pharmacists, the focus was on what is the local guidance, what are the predominant antibiotics that you're giving, and what does the guidance say about rate of delivery, rather than sort of clinical questions that were targeted at the emergency medicine and pediatric physicians. So the majority of clinicians reported that IV access limited the timeliness of delivery of medications in sort of these kinds of resus scenarios, sometimes or often. And as we kind of expected, 93.5% of the vast majority of clinicians reported ceftriaxone as their first-line antibiotic that they used. In terms of the rate of delivery, we found quite a wide variation between clinicians in terms of how the ceftriaxone was being given. So for those of you that are from out of region, ceftriaxone is we have 50 milligrams per kilogram ceftriaxone, which is often given as a broad spectrum antibiotic for sort of generally unwell children. If there are any sort of neurological concerns, so septic shock with reduced GCS, or for example status epilepticus with fever and some concerns that there might be a meningitis or encephalitis type process going on, then usually the dosing is 80 to 100 milligrams. And so with that sort of dosing, what we kind of found from the survey was that sort of about a fifth of respondents were giving the antibiotic as a slow IV push. And then 12% were giving it as an infusion over 10 minutes. Close to 40% were giving it as an infusion over 30 minutes, which is what is sort of described in the BNF. 12% were giving it as a split dose, where they were giving 50 milligrams per kilogram as a push, and then 30 milligrams per kilogram an hour later to top it up to a total dose of 80 milligrams per kilogram. And then a small minority were giving an initial dose of 50 milligrams per kilogram and then going to once daily and giving a full 80 milligrams per kilogram the following day. So quite sort of wide variance in in a situation where you might have a child who's quite unwell, and where we know that sort of standardized practice is probably the most helpful for the whole team. And so this sort of bears out, I think, what we suspected for the regions, that there is quite a lot of variation. There are also a few centres where we had multiple respondents. We had 11 trusts where we had multiple respondents from, and interestingly, in every single one of those trusts, there was a difference in the rate of delivery between the clinicians that responded from that trust. And so you could imagine these were all sort of consultant pediatricians or emergency medicine respondents. You can imagine this might leave the team feeling a little bit confused about how to approach delivery of antibiotics in these resuscitations. And 9 respondents themselves identified that there are at least 2 different approaches that are being used commonly within their trust. In terms of why this might be happening, I think the reason is because IV access is limited, and we know that correcting shock in septic shock, or getting on with loading with phenytoin or whatever the next anti-epileptic agent might be, is really important in status epilepticus. And so the motivation for moving away from the 30 our infusion, I think, is often line space and wanting to get on with other things. So it comes from a good place. And I think it's a reflection of, you know, people innovating and trying to sort of deliver good care, but without perhaps any standardized guidance about how to do that. And so, yeah, I guess where does that leave us? So I think what this shows is that there is, I recognize that there's sort of a 44% response rate, and, you know, within 2 regions, but it's suggestive, at least in the centers that we surveyed, of variations in antibiotic rate administration. I think what we thought was that the need for resuscitation and limited IV access were probably the drivers for this practice deviation. It felt to us that some of the dosing regimens risked emission errors or subtherapeutic dosing. So you can imagine that if you give 50 milligrams an hour and the plan is to give 30 milligrams in an hour's time, that there could be emissions, or it could happen in, you know, late, and so there'd be sort of subtherapeutic dosing of antibiotics. But equally, some of the practices, like giving push dose ceftriaxone, which I think was historically done during the meningococcal sort of epidemic of the 80s and early 90s, is outside of the summary of product characteristics, particularly for children under 12, for various reasons, including kind of risk of vomiting, poor tolerance, and biliary sort of lithiasis. I've forgotten the right word for it. There is, however, some safety data for infusions over 10 minutes, and it felt to us that if clinicians are trying to avoid the full 30-minute infusion because they're trying to preserve line space for resuscitation and things, that this could be a good compromise, which has got a good safety profile, doesn't risk omission, and gets things done relatively quickly. And so on the basis of sort of all of this, it's one of the things that's been instituted at Addenbrooke's for the last year, with good with no sort of adverse events, and sort of reported to be kind of quite well tolerated and liked by the nurses and clinicians. So yeah, thank you very much. Does anybody have any questions about this? I'd be interested to know what people are doing in their own centres, or whether they've experienced similar issues. Stunned silence. Okay. Well, in that case, we should move on to Dr. Damien Rowland. Damien, are you there?
Hi there, hope you can hear me.
Thank you very much for joining this session. I'll hand over to you.
Hopefully. Can you see the screen?
Yes.
Are we full screen? Just to make sure I'm not presenting half my slide deck. Yeah. Okay. Good morning, everyone. Thank you very much for the invite. My name's Damien. I'm here on behalf of PERUKI. PERUKI, if you don't know, is the United Kingdom and Ireland's network for pediatric emergency research. We have a large committee now, and we are currently chaired by Niall Mullen, who is a PEM consultant from Sunderland, and PERUKI was initially founded by Mark Little, a PEM consultant in Bristol. And as you can see, as part of our committee, we have both kind of nursing membership, trainee representation, and representation from Ireland. I'm constantly forgetting that we are PERUKI, UK and Ireland. Please pick me up if I forget the Ireland in the future, because they're an important part of our group. And we have a large number of sites who are part of this network now. We've grown from what was originally, I think, about 22 to 23, and we're now well over 60. And hopefully, because kindly the Royal College and especially the intercollegiate Committee on Standards for Young People recommended that every emergency department in the country that sees children should have a link to PERUKI, our membership has really blossomed. And we're a unique network in the fact that we have millions of patients, and I mean literally millions of patients presenting to one of our sites across the UK and Ireland every year, which enables us to do research at scale and at pace that other pediatric specialties aren't able to do. I'm going to talk a bit at the end about getting involved in research, but mainly I'm going to talk about some of our very recently published studies, our current studies, and what we're thinking of doing in the future. I'm very happy to take questions at the end. One of the things that we did at the very outset was ask our membership, which is essentially all our sites, what they thought the most important things were to be able to research. And this was a Delphi exercise, a prioritization exercise, and these were essentially the top 10 items that came up. And what we find is that biomarkers for predicting serious illness in children, I'll discuss that. Identify needs to go to a major trauma center. We've got ongoing work. A UK version of PEMEast. So PEMEast was the study in Africa which demonstrated potential harm from fluid overload in sepsis. We have had a UK version of that. What's phenomenal about that study is it essentially demonstrated that children aren't sick enough in the UK to be able to replicate PEMEast. We simply cannot do a study that would be able to really show that fluid boluses could make a difference, because we don't have enough children who need loads and loads of fluid, which is slightly contrary perhaps to some of the public messaging about sepsis and how common it is. And what this means is that we're going to need to do worldwide studies of this, and that is happening at the moment. We're constantly striving to look at how we treat asthma, and then there's a whole load of bits and pieces that I will pick up later in this particular lecture. Just to start off, and I'm presenting this because I think this is our most recent big outcome. So this was the CAPIT study. What CAPIT was essentially doing was taking an amount of an antibiotic, saying, do you need a low or high dose of that antibiotic, 30 milligrams per kg or 60 milligrams per kg, and do you need to give that for 3 days or 6 days for children presenting with what was presumed to be community-acquired pneumonia. And as we know, this is a pretty vexed question, and pneumonia seems remarkably common, but actually the evidence is beginning to suggest that we probably overtreat, and especially with the concerns about antimicrobial resistance. This is a really important study, and that's why the NIHR wanted to fund it. So essentially, there was a low and a high dose regime that ran across 3 days or a week, and so you could be randomized to any one of 4 arms. And what we found is essentially there was no difference between either dose or duration. And this particular graph demonstrates that the resolution of cough, which was an important patient-centered outcome, it really made no difference about whether you were at the lower or higher dose. And if you look at the short or long course, it does appear that for the slightly longer course, the cough resolved slightly earlier. But that is essentially a matter for parents rather than clinicians. And this is the really interesting part of this study, is it's really begged the question about what that families actually want and what is their expectation. But importantly, and if I go back to this graph, you will see that actually for up to 21 days in the study, there's still a fair amount of children with cough. So one of my immediate practice changes is to start advising parents that it doesn't really matter whether I give antibiotics or not. Your child is going to have a cough for a considerable period of time. And one of the other findings was CAPIT is there was a huge rate of return to GPs or EDs for more health-seeking behavior. And what that implies is actually, I think, parents want a complete resolution of symptoms, and they're simply not going to get that, whether it's bacterial or viral. And so I think there's a numerous more studies to do, both qualitative and quantitative. And probably the most important one is a randomized controlled trial of children with simple pneumonia where you don't give them any antibiotics at all, because they're probably going to get better anyway. And that study is actually has been undertaken, and there's another bigger study being undertaken in America as we speak. So what have we got going kind of right at this moment? We literally just finished and are writing up Dimples. So I'd be interested in the chat or in the discussion at the end. How many of you thought that diabetes presentations, and in particular DKA, increased during 2020? This is one of those really interesting questions. As an anecdote would suggest it did, but the data is a bit mixed on trying to work this out. So Dimples is essentially a retrospective study of looking at diabetes presentations, new onset and children with diabetes, and whether they came in with DKA and what the severity of that DKA was, looking at 2018 and 19 versus 2020. And we're writing this up at the moment, and hopefully we will get those results to you shortly. Episodes is a European study that PERUKI have been part in with another European organization called REPEM. And what we were looking here is getting emergency departments to send in data about the number of presentations they were getting for particular conditions, and looking at that change over time. And the interesting thing that came out of Episodes, which we're going to see if we can match or validate with Dimples, is it appeared that while diabetes presentations appeared to increase as a proportion, in terms of raw numbers, they perhaps weren't that much different. And one of the hypotheses is because we were seeing less really well children during the pandemic, other conditions appeared more severe than perhaps they actually were, because there wasn't that mixing. But we need more data to confirm that conclusion. Another study that we've just finished doing, and I've not even seen the results of yet, they're just being analysed, is asking clinicians about their use of IV magnesium. Personally, I'll explain about it. I hate IV magnesium, and actually that's not true. It's not that I hate it, but it's a bit of a medication like an adrenaline nebulizer in croup. Is that if you see someone you think is unwell and you give it to them, they're going to appear to get better, and your use of that drug is therefore justified. But whether it was needed in the first place is a very different question. And what's happening in the North American countries at the moment is they're using IV magnesium to turn around children very quickly and then discharging them within a 2 to 3 hour window, which in the UK, a lot of people go, oh, okay, I'm not quite sure about that. And so what we're trying to do is compare UK practice, Australian practice, and American practice to see if we can then start doing a proper study on the utilization of IV magnesium. A study that I hope some people are recruiting to as we speak is BronchStart. So what we decided to do as soon as we heard that the Australians and New Zealanders had had this huge wave of bronchiolitis as soon as they came out of lockdown, we started the mechanism of doing a prospective study for when we came out of lockdown last year. And we've recruited so far over 11,000, probably nearly 12,000 now patients, and are being able to describe the epidemiology of RSV in 2021. I think some of that data has already been released via the public domain. And I think what we've got is we didn't quite get that super spike that New Zealand got, but we did have a more prolonged season of bronchiolitis than we would get over the winter. And what BronchStart is going to be able to tell us is what was the overall severity. My personal anecdotal experience is that although we did see bronchiolitis and we saw lots of it, it wasn't quite the severity as of previous years. And the other question we need to answer is what is going to happen over the next couple of months? We've come out of lockdown completely. Are we going to see a second wave? And that's what happened in France. And BronchStart is going to continue to recruit into May to see if we can pick up that particular wave. Bronchstart works through REDCap. I'm showing this because I think we are changing quite rapidly to electronic data collection tools and just removing paper completely. And I think that helps a lot of people's research endeavors. And if you're interested, and I'll share the link in the chat when I finish, it's a bit complicated and not easy to show on a shard, is we have a day-by-day real-time update of the amount of bronchiolitis seen across the country in all the sites. So you can see how your particular site is performing compared to other sites. Fourth study, so that's being submitted to a journal at the moment. So this was looking at buccal fractures in children. The X-ray there, for those of you who don't work in emergency care, is what's called a buccal fracture. It's more of a bulge than a break. And there's good evidence now that we don't really need to treat these with anything. And that's what the fourth study did. It compared a typical splint to simply wrapping the wrist with a crepe bandage, which the parents asked for, but actually doesn't really do anything clinically apparent at all. So this was a large RCT. We recruited well over 800 patients, and we're basically going to see if a really common presentation, we can throw the book out. We can literally say, look, you've got a buccal fracture, take some pain relief, go home. Related to Force's craft study, this is also run by Mr. Dan Perry, who's a pediatric orthopedic surgeon and is a worldwide leading expert on kind of pediatric orthopedic studies. And the craft study is essentially asking this question: if you've completely nadgered your radius on the sin of wrist fracture, do you need to do anything with it in terms of going to theatre, or can you just put a plaster of Paris on? And the reason we asked this question is because in Hawaii, for a period of time, they ran out of anaesthetic to be able to take children to theatre. So for a period of time, they just put all of their wrist fractures in splints and they in plaster of Paris, and they all recovered, as this X-ray shows, to the extent where you could have an absolutely horrendous wrist injury and it still get better. And this is really causing some shockwaves, because there's orthopedic surgeons say, there's actually no way in my life am I not taking this child to theatre. But the evidence suggests that we might be able to avoid doing that. A study which has been going on for a long time because it's very difficult to recruit to is Magpie. This is Penthrox. Those of you who have worked in Australia may have heard it called the green whistle. This is basically a portable Entonox, basically, and it's been licensed in Australia for a decade. No safety problems, no problems at all. But one of the problems with research is people like governance. And what the MRHA decided is they didn't want this product to be licensed in the UK without a formal evaluation of it. So we're having to do this RCT to get a medication into the UK, which we know works in other countries, which is frustrating, but that's the way we're going. This is a really challenging study to recruit to, because you have to get the child consented very early on their presentation, really affected by COVID, but we're continuing to get there. Now, FIDO is going to start hopefully in the next couple of months. This is going to be a study looking at the evaluation of the management of less than 90-day-olds with a fever. And this comes on the back of the Petechiae in Children study published in 2020. So what we did was we basically looked at all children presenting with fever and petechial rash and found actually the incidence of meningococcal disease is extraordinarily low, but it's not non-existent. But actually, if you look well and you've simply got petechiae, not purpura, just petechiae, what that means is you can probably get away with observing, and as long as there's no spread of the rash, you don't need to treat. And I hope one of the things that I'd really like you to look at is the British Society of Antimicrobial Chemotherapy Pediatric Pathways website, because there's a whole selection, including PIC and management of the febrile infant, that have gone into these pathways and are hopefully going to start challenging NICE about some of the, I suppose, more formulaic approaches that if you've got this, you have to do this. These pediatric pathways are pragmatic, they're evidence-based, and we think they're safe. And the FIDO study is hopefully going to help start informing our management of this really tricky group, especially the less than 6 to 7 week olds who present with fever. What do you do? How do you manage them? Who always needs antibiotics? Who needs LPs, etc. From an international perspective, PERUKI is part of PERN. PERN is the international conglomerate of emergency networks, and we've just submitted all our data for PAINT, which is the largest study of intussusception that's ever been done, looking at analgesic options. And it's really interesting starting to see the variation. When you see a child with intussusception in your department, when you send them for their insufflation, what pain relief do they have? And one of the things I would do now is start asking your radiologists, do you provide morphine or other medications for when they are having that procedure done? Because there were some really interesting findings from this study. We've got a whole load of stuff that has come out over the last couple of years. But things that are on the horizon, I know that you're going to be talking about management of status. The Crescent study is a completely novel way of looking at status using a high CO2 mix with the oxygen, which changes the pH of your brain, which is felt to stop status. We're going to be looking at that vexed question of atraumatic limp. How should you manage that? Outcomes from magnetic ingestion, what dose of cefalexine do you need for UTIs, and hopefully starting some registry type studies for anaphylaxis. Just to let you know, we are now an affiliate of the NIHR, so we can sometimes not only support studies, please go to our website, look at how you can come up with your own idea for a study and pitch that to PERUKI, but we can also provide a little bit of money for that twice a year. And just to finish off with quickly before I run out of time, things that you can do to help the worldwide, or at least the UK-wide child health endeavour. Look at doing GCP. I know it's boring mandatory training, but once you've got GCP, you can help recruit in studies. And I think that is really good for your kind of portfolios. And I think more importantly, whether you're a trainee or a consultant, research is going to be seen as a continuing professional development item, a bit like education is now. You need to prove that you can deliver education for every 5-year cycle. And I think you're going to be able to do the same for research. And we're not asking everyone to be academic. What we want to do is people be aware of research so that they can have informed consent for their parents so that they can help their own practice and outcomes for children. And speaking either to your local PERUKI site or R&D centre will help you do that. And I can share these slides at the end, which give links to other things that you can get involved in doing. I just wanted to highlight the Associate PI scheme, though, which is a really nice endeavour, which it links kind of junior clinicians who are interested in research and pair them with a principal investigator so they can get research experience, and we can start building a pipeline of people with capacity. This is a quote from a PERUKI member, and I love this quote, and I think it sums up what PERUKI does. We are there for active clinicians. We're not there for people in ivory towers and academia. We want to do research that is meaningful for everyone on this call. And I look forward to questions. Thank you very much for your time.
That was fantastic. Thank you so much, Damien. So we've got some comments in the chat, and there's a question there. Is there any outlook for Magpie to finish?
Good question. So we have been really, it has been a struggle. Stuart Hartshorn's leading on this, and there have been both kind of difficulties with COVID and difficulties with making sure that the protocol is fit for purpose. We will get there because there are more sites coming on board, and as we move towards the summer, as lockdown ends, there will be more children presenting with injuries. It's just going to be at least another year, I suspect, before we get the numbers that we need. But I think as soon as we've got those numbers, hopefully we will have something that we can get published as soon as possible, and get Penthrox out there. It's a struggle. There's a lot of ethical challenge for this study, mainly because should you be doing a study in which there isn't equipoise? And that raises lots of questions. And I will be writing to the MOHA after we've done this study to highlight some of my discomfort with why we had to go through this process, given the evidence that was available.
So a question from Richard Brown is, how do we make sure that practice-changing papers from PERUKI are being disseminated amongst healthcare professionals working in PEM? I found that CAPIT isn't widely known amongst doctors and nurses where I work.
Yeah, excellent question, Rich. So, I mean, part of that's on us and our dissemination processes. So there's two answers to that. One is that I think we have seen an uplift in PERUKI sites. And one of the things that I've always wanted PERUKI to do is it be its own dissemination network. You're part of studies, you're aware of them, and then you see the outcomes. And I don't think everyone is particularly linked in to a PERUKI site. But most importantly, perhaps at a local level, although we're pushing information out to the PERUKI site leads, perhaps those PERUKI site leads aren't pushing that information out locally. The other thing is that we have a collaboration with Don't Forget the Bubbles. And actually, specifically with CAPIT, we've just completed a video. It's literally 7.5 minutes long, and it explains CAPIT in its entirety. And that started to be shared on social media, and we will be sharing that through PERUKI networks as well for people to take to their teams. It's a really easy watch, and I think it's something that I've been keen to do for a while. I think people don't always like reading the full paper, but little infographics don't give you the information you need. So we've got Tessa Davies, who leads Don't Forget the Bubbles, kind of just doing a video cast, basically, like a YouTube channel of PERUKI dissemination. And that's one mechanism that we need. But what I really need is everyone on this call is to listen to what I talked about, get interested, maybe ask me questions, ask questions of PERUKI, and share that love and knowledge. And then a quick plea is that PERUKI runs something called Bubble Wrap. So every month we do a review of 5 to 6 papers. That is available to everyone to do. So if you are a trainee or a consultant, a research nurse or a nurse who's interested in improving your own evaluation skills, please get involved. We can give you can find a paper yourself, or we can find you a paper for you to analyze, supervised by someone like myself, and you will get that published on the Don't Forget the Bubble site. And that website now we have a DOI for, so it comes with a mini citation that you can put back in your portfolio. And for the question on links to your studies, if you go to the PERUKI website, you can just look for studies and just click on them, and that will take you to the PubMed reference.
Thanks. And Ronald, you got a question in the chat. Do you want to unmute yourself and then present your question?
Yeah, it was a question about the presentation of diabetes during COVID. It appeared that it will be presentation to only ED. Will it include well children presenting from GP referrals? Because we have seen anecdotally from our own practice that there was a huge increase, about 150% increase in the overall presentations. But if we look at only ED presentation, that may not be significant.
Yeah, that's so excellent comment. So the Dimples was specifically for ED because that's where we can access the data. We think, and I'm pretty sure that this is the case, that the National Diabetes Audit will pick up those children who presented to pediatric assessment units. PERUKI, which is the sister of PERUKI, is the general pediatric version, basically, haven't done a similar piece of work. But one of the interesting things is that I think through hopefully the National Diabetes Audit, we will get that data, because an inference of what you're saying is that one of the things that may have happened during COVID is that the EDs may have picked up a sicker cohort because I know during COVID, a lot of children's children's departments became the first point of access, and their local ED stopped seeing children, and they all just came to the assessment unit. So there may be many children that we missed through dimples, but we only did report the ED arm of that.
Brilliant. Well, thank you very much, Damien. That was excellent timekeeping. I can't believe how quickly you rattled through all of those slides. So that leaves us with 12 minutes before the next session. Richard, do you want to start on 10 and give people 10 minutes for a coffee break, or would you like to get going?
The gift of time. The gift of time. I suppose there's two options, which I will leave to you as the boss. So I think that Srini Teki Rao has got a short presentation on the Eclipse study and levetiracetam in status epilepticus, which we could start a little early just to give him a little bit longer, because it's always a difficult thing to do in 10 minutes. Alternatively, we could just give people the gift of time and return at 10. So very happy either way. We haven't got the full panel yet to properly kick off, but as I say, the first few minutes should be presentation rather than discussion. I'm sure that we will require our full hour.
In that case, why don't we say let's start at 5:02, and that gives people 5 minutes to grab a coffee, and the rest of the panel some time to join.
Perfect.
Okay, thanks everyone. So we'll pause things for now and restart recording at 5:02 on the dot for Dr. Teki Rao to present about status epilepticus.
Give me a green signal when I should start.
Sure, I think this is a good time. So welcome back, everybody. Thanks again for joining this morning session. So the next hour is going to be a panel discussion about the proposed upcoming changes to the status epilepticus guidelines. So some of you may be aware, but there's been a little bit of chatter about these guidelines, which I think are currently going through ALSG and BPNA approval. And there are a few relatively significant changes that have been proposed, and we thought it would be worth exploring that in a little bit more detail to understand what kinds of changes we might be looking at and what sort of the implications of those might be, as well as understanding the rationale for some of those. So to begin with, Dr. Teki Rao is kindly going to present a little bit about the changing scenario.
Thank you, Ash. Hi, everybody. My name is Teki Rao. I'm one of the pediatric consultants at Liverpool Hospital and lead for Pediatric Epilepsy Service. We're also part of the East of England EPEN, Eastern Pediatric Epilepsy Network group, and I had an opportunity to participate in status epilepticus guideline group that actually worked on changing these guidelines, which has been quite old, and based on the recent evidence that has emerged between 2018 and 20. So basically, I'm going to give a 10-minute presentation, briefly taking through the guidelines and the background behind this. So first APLS manual was published in 1997, and it is updated every 5 years. The latest evidence was, the latest version was in 2016, and I think there is a 6E edition is there, but there is one 7th edition might be due. Probably there are more people who have seen the 7th edition, but I haven't had an opportunity to see that yet. For this, we have worked on several members between 20 and 21 to just review the evidence and wanted to update this guideline because there is a lot of change in practice all over the world, including USA, Australia, and even in UK, having seen emerging evidence of status epilepticus being similarly useful as phenytoin, people have been started moving into that. So we were waiting for an appropriate evidence. So what this guideline is intending to do is keep the same ethos and principles, but basically this doesn't apply to, like previous guideline, non-convulsive status epilepticus doesn't come into picture of managing. That needs to be discussed individually, or again, there are no enough guidance on that, even on research front. Super refractory status epilepticus, again, this comes into PICU arena. So we don't want to just touch on that. And then if someone has got an individual emergency care plan for management of their own seizures, I think this guideline doesn't apply to those cases. So, but what has not changed is, importantly, ABCD, effective resuscitation is really important. Very early recognition, starting the ball rolling right from the community is very essential. So this is applied to even the paramedics who go to the community before starting the treatment as well. So this can be used from that scenario from point 0. Treatment of ongoing convulsion. So early we do that, early we improve the outcome. Assessment of ABCD is essentially crucial. And again, in this protocol, if you look at it, every step they say, have you assessed ABC? Have you assessed ABC? So that kind of emphasis is there all the time, because we do miss sometimes basics, and then a lack of oxygen or hypotension not managed might actually make intubation, etc. And then ultimately the outcome will be very poor. Identify and treat the causes, then termination of convulsion and prevent recurrence, reducing the risk of mortality and morbidity by early intervention, and as much as possible avoiding admission to PICU. So these are the key aims. What has changed is basically the time interval between step 1 and step 2. So we kept benzodiazepines as the first line management, so dose 1 and dose 2. However, the time between step 1 and step 2 has been changed to 5 minutes. I can explain the reason behind either in the discussion or during the further conversation. And then second line drug has been replaced by levetiracetam rather than phenytoin, based on the recent emergence of guidance. And then in step 4, when the team is ready, instead of giving another anti-epileptic drug, as much quickly as possible, we should go to rapid sequence induction. But if the team is not ready, then we can give phenytoin or phenobarbital as followed by levetiracetam. So if I take you through the quick steps, I hope you can see fully. First is securing the airway, high flow oxygen, and consider reversible causes. So again, individual emergency plan takes precedence. And if there is an anesthetic support is needed, if the ABC is a concern, for example, child needs an intubation because of compromised airway or something, that should take a precedence even before giving all these drugs. The same as before, if there is a vascular access, go to IV lorazepam. I'm just talking about 5 minutes from the onset of the seizure in this case. I'm not sure whether, are you able to see my the pointer?
Yes,
we are.
Yeah, thank you. So lorazepam, as usual, as in the previous one, if there is no vascular access, either we could go to buccal midazolam or diazepam. And again, the strengths are mentioned here. If there is no control of seizure in the next 5 minutes and the convulsion is ongoing, check EBC and continue to monitor. Second dose of benzodiazepine should be kept ready. Again, depends upon the vascular access. If that is yes, we can go for IV lorazepam because it's a quick onset of action within 1 to 2 minutes, compared to buccal midazolam, it can take between 2 to 8 minutes. And if there is, either you can choose midazolam or diazepam. So until now, there is no change except the time interval between the first and second dose of benzodiazepine is reduced to 5 minutes. After that, waiting for another 5 minutes and going for levetiracetam loading dose at 40 milligrams per kg, IV or IO. Again, we left this to the local protocol as to how do you want to give infusion, even though in the main writing of the whole guidelines, there are some recommendations as to giving 0.9% saline, 1-to-1 dilution, and giving it over 10 minutes. 5 to 10 minutes. Basically, we can give in 5 minutes. And then waiting for another 5 minutes. So totally 10 minutes from the start of the infusion. 10 minutes after the finishing of the infusion. So it will be totally 15 minutes if we include that. So 5 minutes for the infusion and wait another 10 minutes. By this time, if there is no convulsion control until this time, then if the team is ready, we need to go to rapid sequence induction, either with the ketamine, thiopental, or propofol. Again, the guideline group is hasn't got enough evidence to choose which one is better. Therefore, they left to the local teams to decide on which one they are quite convenient with. However, if there is not readiness in terms of rapid sequence induction, we can go for either phenytoin. If the child already on phenytoin, go to phenobarbital. Both are 20 milligrams per kg, IV or IVO, and the maximum dose has been mentioned here. At this point, again, there is no other alternative except to go for rapid sequence induction if these features fail. But again, this should not stop you from intubating this step here. So basically, even though the step is included here, it's only for this non-readiness. So I am just going to discuss about the Eclipse study and 3 studies based on the decision change. So this Eclipse study was conducted in UK, again with the PERUKI collaborative. They compared levetiracetam versus phenytoin for the second-line treatment. They have included 286 children. It's an open label study. Children between 6 months and 18 years. Totally 152 children were in levetiracetam group, and they have used 40 milligram per kg infusion over 5 minutes. And on phenytoin group, there were about 134, which was used at the rate of 20 milligrams per kg, and infusion was given as like previously 20 minutes. So the result is that seizure cessation was seen in 106 children in the levetiracetam group, which is about 70%, whereas in phenytoin group, it is 64%, which is 96 children. So there is no significant difference. And the median time for cessation from the start of infusion, both the groups, is 17.5 minutes in levetiracetam and 24.5 minutes in phenytoin. So there is a slight difference in the timing in terms of cessation of the seizure. But overall, there is no difference in levetiracetam or phenytoin, but levetiracetam is favored because of ease with which we can administer and safety profile compared to phenytoin. The next study at the same time when Eclipse was taking place here, New Zealand and Australia concept study took place. It compared again, similarly, levetiracetam versus phenytoin. Again, they used the same doses and a similar number of children, 233 children between 3 months and 16 years. And levetiracetam group 119 at the rate of 40 milligrams per kg for 5 minutes. And then phenytoin, 112 children, 20 milligrams per kg. Again, the same protocol similarly, but there was some extension, which I'll talk in a minute. So seizure cessation in 5 minutes after completion of infusion, that's what they look for. There is a 50% success in levetiracetam group versus 68% in phenytoin group, which is, 68 children, which is 60%. So again, there is no significant difference between both groups. And the median time to cessation from the start of infusion is 17 minutes, like the same in UK, 17 minutes in levetiracetam versus 22 minutes in phenytoin. There are no serious adverse events or death in any of them. And conclusion is that levetiracetam is not superior to phenytoin. That was their conclusion. So they did an extension study, which is actually not part of the primary outcome. What they wanted to look at is, they have given, even though they first looked at the outcomes of levetiracetam and phenytoin, in some children, they have added phenytoin for those who have received levetiracetam and levetiracetam for those who received phenytoin. So levetiracetam infusion 5 minutes finished, waited for 10 minutes, then phenytoin infusion was given for another 20 minutes. This all adds up to total protocol to another 5 minutes extension. So that is total is 35 minutes. Again, if you go this route also, it takes the same way. The total, both groups, it finishes in the same way as 35 minutes to the end point. So what they compared was in the phenytoin group who have received levetiracetam, there was an initial 60% success rate, and then adding levetiracetam, that extra time, given a further reduction of another 37% success. So total comes up to 78% having added 2. Similarly, in levetiracetam group, they added another 40%, so nearly 90. Totally, it comes to 72% total success rate at the end of 2 hours. So it's only 22% of all these cases required rapid sequence induction. But obviously, this secondary outcome was not in their main conclusion of their study. So there is one other study in USA, which is ESET. They compared levetiracetam, and USA they used phosphonatoin and valproate. So they compared both children and adults. There are about 225 children and 237 adults, and some elderly, about 57. Primary outcome is absence of clinical seizure at 60 minutes with no additional anti-epileptic drugs required. So levetiracetam, they used, actually, if you remember, we were using 40 milligram per kg and they were using 60 milligram per kg, and phosphonatoin 20 mg per kg, which is not available in UK for various pharmaceutical reasons. Valproate is used at 40 milligrams per kg IV. So the success rates were levetiracetam 52%, phosphonatoin 49%, and valproate 52%. Again, there is no significant difference between the groups or age group differences either. And adverse reactions are rare. So actually they say either of these drugs could be chosen, and in their emergency protocol now they put it as one of them. You can choose any one of them before going into rapid sequence induction rather than one after the other. So any of these can be the first choice or second choice after benzodiazepines. So I will leave further discussions later. I conclude that CSE is a very a medical emergency that needs to be very time critical. We need to be very swiftly acting. In UK protocol with these new changes also, we wanted to keep the time limit to 30 minutes because there isn't any outcome differences if you continue to prolong your status management in the local. If it goes beyond 30 minutes, outcomes remain equally poor, whether it is controlled by your local protocol or rapid sequence induction in a PHE protocol. Therefore, the time critical nature of trying to manage it within 30 minutes is really essential. Thank you.
Thanks so much, Srini. That was an absolutely brilliant presentation, and it's really good to hear this sort of presentation from the horse's mouth, i.e. somebody that's been involved in the new guideline generation. So we're really grateful for that. Thank you for getting us started so brilliantly. My name is Richard Brown. I'm going to be chairing this particular session at the kind invitation of Ash Patel. I am a paediatrician at Addenbrooke's, and I am the erstwhile chair of the Eastern Pediatric Epilepsy Network, and I'm currently chairing the Open UK National Confederation of the Regional Epilepsy Networks. So you can see that epilepsy care in this country is very intentionally and very firmly networked, so that we peer review each other's practice and make sure that we're not working in silos. Between Ash and myself, we've invited some panel members to help us to work through this new guidance, so that we can try and work out what we feel about it and what we might do in our local centres. I think in terms of how I would sell myself to chair this discussion is that I'm currently working as a paediatrician in Addenbrooke's, but really importantly, I've worked as a consultant paediatrician in Peterborough for 8.5 years. The reason I think that that's important is that all of us in our different roles may come to have different perspectives on how to interpret the evidence and what we should do in these particular situations. And if you've been up for all night with a child on a ventilator sitting on an adult ITU waiting for a retrieval team to come and get them, it will change your perspective, rather than when you can simply ask PICU to come down the corridor and take them up there. So I think we all have to have a different perspective about things from where we stand. But in order to achieve that balance, we've got a panel today of experts who also represent different parts of the pathway. So I'm really pleased that we've got Srini, who is also the erstwhile chair of the Eastern Pediatric Epilepsy Network. And we're lucky enough to have the current chair of the Eastern Pediatric Epilepsy Network, and also a paediatric neurologist at Addenbrooke's, Pooja Harijan. Give us a wave, Pooja. I'm also very grateful that you've joined. We mentioned 10:30, didn't we? So I'm grateful that you've managed to escape from your meeting a fraction early, so that we can hear from your wisdom. Representing transport, retrieval, and intensive care, I'm really pleased that Kostas Kanaris is joining us today. Hi, Kostas. Your perspective on this will of course be crucial. And again, from the district general perspective, I'm pleased that Nick Schindler is joining us from Norwich. Give us a wave. Now, Anna McCorkadale, I think you're working in paediatric emergency medicine in Harlow, is that right? So again, a fantastic component of our panel today. I am sorry to say that Bina Mukhtiar, a future chair of the Eastern Pediatric Epilepsy Network, I'm sure, is unfortunately unable to join us today because her daughter has injured her foot. So she's probably bothering some PEM doctors somewhere. And it may be that other members of the panel will perhaps surprise us later. And no doubt I'll be picking on Ash and Josie because I know you. Around our sort of the questions that we're looking at, we're going to be thinking about that change in the interval between the first and second benzodiazepine in the new guidance. We're going to be thinking about the potential change of the first line agent that comes after benzodiazepines from phenytoin to levetiracetam, and we can think about the pros and cons and what that means to us. We can think about this question of a procession to rapid sequence induction rather than using the second line agent. And we can have a think about the induction agent that may be used in the emergency department. So for example, having a think about ketamine. So I think, would it be helpful if we were to start off by having a think about that question of reducing the amount of time between the first and second benzodiazepine? So Srini, you were saying that the time, the pre-existing time within the ALSG guidance was that that 10 minutes after the first dose of benzodiazepine, you would then give the second dose. Why are we proposing to change it to 5 minutes?
So I think that basically there are some studies which looked at the difference, the response to first benzodiazepine, if effectively given, is 70 to 80%. And having added second benzodiazepine, it only adds only 17% further success rate. And therefore, so further delaying another 10 minutes is not going to be hugely beneficial. Therefore, they decided that we should add 5 minutes and then give another 5 minutes and give this dose. So therefore, we can totally save some time, and also effective, if at all, both can be working, but not more than 2 doses. That was very clear.
Okay. And Anna, what do you think about that? Would that change your practice? Would you reduce the interval between the benzos?
I think that of the proposed guideline changes, this is quite an easy one from a district general perspective. It's something that when we know someone is coming in, we can get ready quite quickly. Often they've been given a dose in the community. So in some ways, the proposed 5-minute change might not have as big an impact in hospital as we're anticipating, because if a dose has been given in the ambulance, we're going to be ready to give a dose anyway. And so whatever interval that is, it's going to be as quick as possible. So in reality, of all the changes that are there, this is probably the easiest one from a district general perspective to manage. So yeah, I think it would change practice. I think we would have to know it was coming in. We would sim it. Is sort of how we try and get our trainees to, or everyone that's on board, and our whole emergency staff to know that we are thinking at a faster time schedule. But I think that that's probably the easiest one to bring into line, really.
One thing, if I may add,
yes.
Sorry, can I just quickly add something also? Even though practically that is given the time 5 minutes, practically sometimes there may be some further delay as well by drawing and giving it. And also if the first dose was given in the community, there is a big gap, like 10 to 15 minutes before the second dose given in emergency medicine department. Therefore, all this taken into consideration, 5 minutes is not going to be disadvantageous if that can be effectively given.
Yeah, I think that most of the time something has been given in. I feel like in my practice, most of the time, or more than half the time, something has been given in the community. So we're really already looking at a lag of 10 or 15 minutes before, and we would get something drawn up as the child's being brought in, because it would be a red call. So I think that it's a reasonable change from what you've said in terms of effectiveness of the second dose, but also I don't know that it radically changes how we prepare ourselves. There's often something given in the community.
Okay. Costas, what do you think?
So Damien in the chat room, I was expecting that from Damien, but he didn't disappoint. He's asked us to consider the implications of children getting too many benzos. Now, I obviously have a very different and more sort of skewed view of kids with status, because I just get referred the sickest and the ones needing to be tubed. So nowhere near the bulk ED or a general pediatrician would see, because I just see the ones that are sent my way, which are often the ones I need a tube. But I would say, and there's no sort of hard evidence on this, but from the children that we get referred to that are needing the tube, I would say about 70% are the ones that have been given too much benzo in the pre-hospital setting, and this is important to clarify. By no means it is a criticism to the to paramedic teams who are doing a brilliant job, but I think that is something we need to consider, and clarification of the dose given is important, because often they're over benzoed because they're giving a higher dose because they have a one-off standard dose that they give, and then these children stop breathing. So unless we clarify that dose, giving a second so quickly will almost certainly result in them stopping to breathe and at least need bagging, if not tubing, sooner rather than later. These children extubate locally quickly, but it's probably not in the best interest for the child, and it's making more work for us. So it's a lose-lose. Now, if the right dose has been given in the pre-hospital setting, and this has been clarified, if the child's maintaining their own respiratory sort of effort, then I think, given that we can give both phenytoin and Keppra on the run-up to someone earning the RSI, I think that is a good change. It saves us time. And given that only about 15 to 20% respond from the second dose, like Dr. Rao said, I think that's probably a good change. But we need to be cognizant of how much benzo the child has received in the pre-hospital setting. And I think collectively, and I count myself in this, we're not good enough at finding out what dose they got.
Yeah. Okay. So a balance really of the risk of respiratory depression from benzos against the need to crack on and proceed through the algorithm in order to hopefully avoid intubation. Nick, you've got your hand up.
Thanks, Richard. Thanks for that question. So, really interesting, because I think that's definitely our experience locally as well. And for me, more so with rectal diazepam than with other routes. And it would seem that the absorption of rectal diazepam over a 5-minute time frame, I guess it's much more variable. Sometimes you feel like it kicks in 10, 15 minutes down the line when you've just given your second dose. And then the child almost gets 2 doses at once, one with IV once they've made it in, and one when the rectal diazepam from the crew is hit. And I'm wondering if you, Anna, have any sort of thoughts about that, and whether giving rectal diazepam complete equivalence to the buccal or the IV route, maybe it might increase that risk.
Yeah, I agree. I think rectal diazepam, I'm glad you pointed that out, because it's something I'd sort of missed from my chat. Is I do think that rectal diazepam, even given in the right dose, what you then see when they appear with you is very variable in terms of timings. I completely agree with that. And rectal diazepam in the east of England, as compared to London, where I came from, that was my previous job, is given more frequently. There's also a thing in the chat about mums giving buccal and then the ambulance giving rectal. That is 2 doses. I mean, I'd go to panel, but that is 2 doses of benzos to me. I would, if that was coming to my emergency department, we would not give any more benzodiazepines then, and we would move on to stage 3. That would count as 2 lots. I find that doesn't often happen. For me, if mum has given something at home, the ambulance crew are more likely to just transport that to hospital. But yes, I wholly agree. Rectal over and above buccal is quite consistent. I think it gets given, it does or doesn't work. IV is similar. Rectal is very variable. And I've even wondered at some stages where some children on their emergency plans in our hospital have been asked not to give rectal because their chance of respiratory depression is slightly higher. And for exactly that reason, we will then get them at 15 minutes. We will give them an IV dose and they will go into respiratory arrest, because they're both hitting at the same time. So rectal is difficult.
And there's something here, isn't there, about the amount of time that it takes for these drugs to work, isn't there? Because we know that lorazepam is a little bit quicker than midazolam. Srini quoted us 2 to 8 minutes for buccal midazolam to work. And I think I'm right, Srini, that the mean time to work is 6.5 minutes. Is that right?
Yeah, mean time is about 6.5 minutes. That's true.
So you know, by this token, I guess any compression of the time between benzo doses to less than 6.5 minutes is really part of what Kostas was talking about in terms of just trying to proceed through the steps as quickly as possible in order that the ultimate aim of just simply stopping the seizure before intubation and ventilation is achieved, rather than necessarily allowing each drug the chance to work.
There is a lot of variation in practice. Even within England, Scotland are using buccal midazolam by paramedics, but within England, I think east of England is using still buccal rectal diazepam. Most of the England people are using rectal diazepam in the paramedics, and there needs to be a culture shift for paramedics yet to change to buccal midazolam for their use. That's why we have to leave rectal diazepam in the option to be given. Unfortunately, rectal diazepam, as you all mentioned, respiratory depression is slightly higher, even though not very significant. And also it gets accumulated in the adipose tissue most commonly. And again, if you give further diazepines, all this causes later quite a lot of sedative effect. That's a downside of a diazepam than buccal midazolam or IV lorazepam.
Okay. Pooja, I think I'm going to come to you next on the question of phenytoin versus levetiracetam, but is there anything that you wanted to add to that discussion around timing of benzodiazepines?
I think it's just partly a question of perspective, isn't it? Because I think when there's the practical aspect as well as the what I might be interested in, which might be more about the outcomes that we gain from doing this. So I think we still don't have the answers to all the questions about outcomes that we would really like to be able to argue for this. So, I would really like to be able to say to you that I want everybody to be following this guideline, because I'm absolutely sure it's going to improve outcomes in terms of death and disability as an outcome of status, whereas what we're probably limited to is more about the chance of this child then going into an established status, a refractory status, a super refractory status, which is not quite the same thing, and it's not quite as compelling an argument. So I hope that next time we have a meeting like this, that we'll be able to have a bit better data to support this argument.
Yeah. Okay. Well, there's a challenge for Professor Rowland. Good. Okay. Well, let's move on to the next question then. We've heard about the concept and Eclipse studies, and Srini also cited the study from Australia using a different dose of levetiracetam in status epilepticus. The proposed changes to ALSG mean that our second line medication would now be levetiracetam. But Pooja, what do you think about that?
So I think, as Srini's described, the evidence for lack of inferiority of levetiracetam seems to be fairly well supported by the data that we have in terms of the short-term outcomes, and in view of the potential complications of phenytoin compared to levetiracetam, it does seem that in perhaps most cases, there is a good argument now to do that.
Okay. Do you think that people's experience with phenytoin in terms of hazards and risks and harm will influence their perspective on whether this is the right way to go?
I'm sure that it will. I think there's this question of how much of an impact those side effects of phenytoin might have on the immediate management of the child, but also potentially on their outcome of if you have periods of hypertension, etc., and reduce cerebral perfusion. So even I think there's lots of reasons why you would want to move now.
Okay. Costas, what's your perspective on this?
So we need to stress the studies highlighted that the two drugs are non-inferior, but I mean, for me that's a loaded term, and for me there's a clear winner and a clear choice which we advocate when we give advice over the phone to kids that are about to be intubated if they already received phenytoin and not Keppra. Or if they haven't, then we advocate for Keppra first. And the rationale for this is it might be non-inferior in terms of stopping the seizures, but in terms of safety efficacy, there's only one clear winner, and that's Keppra. You have a child there who's fitting. We know fitting for 40 minutes will cause a degree of rhabdomyolysis. You will get electrolyte imbalances and hyperkalemia with that. You don't want to be giving a drug that will cause an arrhythmia like phenytoin, which is recommended to be given whilst on cardiac monitoring, that can offset that sort of arrhythmia, which we have seen happen. It's not often, but it does happen. So why risk the child going through that? The other benefit of Keppra, obviously, is that it can be given fast, and you don't have to wait for 20 minutes for a slow phenytoin infusion to be going in. Now, people gravitate towards ICM and emergency medicine, have an impatient streak, and I'm guilty of that. So whilst giving the Keppra first, you can see a quick result. You can co-run the phenytoin on the side, or without adding to the delay of drawing it up, because most of the delay is drawing things up. But Keppra can be given quickly. Is a very safe drug to give. You don't need cardiac monitoring. You're not risking the child going into a funny rhythm that will make things worse. So yes, they're non-inferior, but primum non nocere is the least harmful option, in my opinion. And given that they have equally good profiles at stopping the seizure, then he should be a clear winner, in my opinion, to reach out for first.
And Richard Appleton, who published Eclipse, said the same thing to me. He said, you know, I've seen so many patients come to harm with phenytoin that I think it's a clear decision. So you know, I think people's experience with phenytoin is always going to change their perspective on this. Nick, you look like Costas was preaching to the converted there. There was a lot of nodding.
Yeah, I'm really grateful for that. And I think just from a DGH perspective, if I can pull that card, our resus is mostly staffed by adult emergency medicine nurses who are much more comfortable and familiar with drawing up levetiracetam Keppra than they are with phenytoin. And I think, you know, it's notable that those studies, the outcome measure is from start of infusion, but I promise you that the infusion starts much faster in our department using Keppra than it does with phenytoin. And so if it is going to be effective, then your seizure cessation comes much quicker. And I guess also from the background point of view, we have a couple of patients on our books who have an SCN1A epilepsy, which is most certainly worsened by phenytoin, and their parents are stalwart defenders of out of hours teams following a protocol and giving them phenytoin. But I always worry that if, you know, a parent isn't there and that no one's read their personal care plan, that they're going to get a dose of something that's going to make them much more unwell. And Keppra makes me much more comfortable with that.
I mean, if I may add, sodium valproate is also a chosen drug in USA, but we deliberately didn't want to choose for reasons that young children, until at least 1 year of age, we don't know some of those mitochondrial conditions being unexplored or undiagnosed. So in those cases, sodium valproate will be a no choice. So therefore, I think best option winner would be still levetiracetam in that case.
Are you not persuaded by Dr. Brown's SANAD 2 paper about the wider benefit of valproate over levetiracetam in epilepsy in general, rather than just status epilepticus, Dr. Teki Rao?
We are thinking about status epilepticus now, rather than, you know, an emergency situation choosing a drug.
Yeah. No, I think that's fair. That's fair. And Anna, where are you going in Harlow with this?
So I think that I completely agree with what everyone's saying, that Keppra is easier to give, it is quicker, and I'm less worried about the side effect profile as well. What I would say is that it takes time to change how we do things, and so I've asked to give Keppra in the last 6 months, and because we don't have a local currently pharmacy approved guideline on what dose to give, it was very difficult for me to get someone to give the dose that I have read in these studies, because so I think there is a little bit around making sure we change our entire processes at the same time, because I agree that the evidence, there's a non-inferiority thing, but the evidence around side effects would favor me giving Keppra. But when I have tried to do that, there is a bit of a reluctance to do it without a local guideline. So I think we have to change everything as a oneer.
I would add that the higher dose of Keppra than what's recommended in the BNF is a stumbling block for many, unless you're in critical care.
Totally.
And we're addressing that from the Panda side. So our new guideline is being ratified. It should be out in the next couple of months as a regional guideline. So you'll have that with the dose and sort of justify things. So hopefully we can start slowly changing the culture in the whole region with the guideline that's regional.
Because it matters that it's not in the BNF for people giving it, for people drawing it up. That really matters.
Absolutely.
So there needs to be a national or at least a regional guideline that would support the delivery of that in a local unit like mine. And just addressing the part of the chat, I have got a lot of Australian. I wasn't part of an Eclipse site, but I've got a lot of Australian colleagues, and they are a little confused about why we're not just doing it. So in Australia, they have just changed their guidelines, and they did that quite a long time ago, really. Sometime during, I think even 2019, early 2020, they changed their guideline. So I agree, Damien, that we are a little behind the curve with our Southern Hemisphere colleagues.
I was checking APLS guidelines of Australia. 2018 edition shows the changes already.
Oh, is it 18? Okay.
They're quite behind.
I was trying to favor us a little by pushing it forwards. 2018, I didn't know it was that long ago.
Well, it's several years ago now that I remember Srini advocating that we move to levetiracetam regionally for the management of status epilepticus. And our challenge at the network is that we ought to wait for the published trials and then potentially influence ALSG guidance. And I think it's very impressive that Srini has not only done that, but has contributed to those ALSG guidelines. And here we are. So Srini always many years ahead of the curve.
Funny enough, we haven't changed our local guidelines yet.
It's always easier to change things regionally rather than locally, isn't it? So that's one of the reasons we've got a good network. Perhaps I think this is controversial, but it'd be interesting to see everyone's different perspective on this. Let's think about rapid sequence induction and possibly going through it a bit earlier. Anna, do you think I could put that question to you? You work in a district general hospital. You don't have a PICU on site, and the new guidance suggests that if you've got a team capable of doing it, that you should proceed to that one step earlier within the pathway. How do you see that playing?
That's probably the most challenging part, I think, for me locally of this guideline. I can imagine changing all the other parts. The teams that we have locally in a DGH, I think increasingly things are becoming more and more centralized. There are less and less local pediatric intubations being done for routine procedures. So the anesthetic team do have, of course, they have experience, and we heavily rely on them, and we support each other. But I think the younger the child gets, the more hesitancy there is over intubating them. And so that will be a hurdle to overcome, especially in the younger age group of children. I think that in your 5, 6, 7, 8-year-old plus, it shouldn't be too much of an issue. We always have anesthetics there. I think when you're looking at seizures in the under 5s, which are probably the greatest proportion of seizures that come in for us, this will be it's not impossible. We have a team and we have all the meds and the drugs. It's the confidence of that team.
Okay.
And so if we're doing it earlier, the other thing I would wonder is, if we're doing it earlier, does that mean automatically a transfer to an intensive care unit, which we don't have on site? So are we going to increase the number of transfers because we're doing this within 30 minutes rather than within 40? Because that's sort of where we're at. So that's, or are we going to start extubating on site? Are we going to start moving towards early intubation, but then an extubation? And that will be a culture shift for both our pediatric and anesthetic teams.
And I mean, so I think we'll come to you, Nick, in order to discuss that. But I think so looking at the new guidance, it does say that when you are intubating and ventilating as part of a rapid sequence induction, then the relevant box is inform PICU and/or pediatric retrieval team. So yes, I think your question about whether earlier rapid sequence induction leads to a lower threshold for retrieval for pediatric and intensive care, of course, is a key question here. And it may be that we need to move through all of the panelists in order to get a perspective on that. Nick, how do you think this will influence what you do in Norwich?
So I was nodding away at Anna's points there, and it's nice that we sort of have we clearly have very similar experiences of things. I guess in Norwich, we are physically further away. I mean, historically, our retrieval service was CAPS and we were very far away. And Pandas has been fantastic for us to feel like we're not quite as remote and distant. But I think we historically wake a lot of children up still in resus or in adult ITU because of the geographical difficulties with retrieval. But I think that we also probably delay the decision to intubate and maybe have that conversation more with our retrieval team. Whereas I think this guidance might push us towards giving Pandas a call and calling to say, I've got this child, they're already tubed, in research, and then our conversation is a lot more limited on options at that point. But from a sort of a personal note, as a relatively new consultant working both in paediatrics and emergency medicine, we have a lot of very sensible conversation with our peds anaesthetists and intensivists who are wonderful. But for me, the decision about RSI is really theirs. It's their skill set. They're the ones doing it. That, I don't know how senior often the trainee is at the head end before the anaesthetic consultant arrives and so I'm quite reluctant to push for RSI in that circumstance, and I think I can see a lot of colleagues avoiding this conversation because they don't feel it's their lane, and I wonder how everyone else feels about that.
So yes, my mantra working in intensive care in 2002 was there's no situation Richard Brown can't make worse by intubating the patient. Costas, you're perhaps more skilled than I in that area. Where do you stand on thresholds for RSI and that question of wake them up or ship them out?
I mean, I could talk for the entire session on this. I would say I've come to the region after 22 years in the Northwest with a fresh pair of eyes, and Nick is in a luxurious position to be in a hospital that has standalone pediatric anaesthetists, and obviously it's a very high performing unit in terms of how they look after critically ill children. Most hospitals don't have the setup that Norfolk and Norwich have. The experience from the region I've come from, and this has been presented and published, but there needs to be more national work on this, and we're pushing with the Pediatric Critical Care Society for this to be done, is that nearly 70% of children that are intubated locally with the right, provided they don't fit certain categories such as trauma, abnormal CT scans with focal seizures, extremes of age like under 6 months old, and a softer one, kids with a complex multi-drug resistant epilepsy that are unlikely to extubate. Nearly 70% of the kids can extubate locally, provided the right anesthetic route is chosen. Now, I can talk a bit more about that, but essentially giving more drugs that stop breathing, probably not a good idea. So opiating them and benzoing them up to maintain anesthesia, probably not a good idea if they fit the demographic that can is likely to be able to extubate locally. So using things like sevoflurane or propofol that you can switch off and assess and extubate seems to work really well. Is there strong evidence for this that's coordinated nationally? Unfortunately, no. Is there strong local evidence for that? Then yes, there's a lot of experience in that department. So then there needs to be a culture change. I would echo Anna's concern, and this is not just isolated to the East of England, this is national. Everything is now being centralized. So we're taking skill set away from the DGHs and doing more and more centrally. And that's not, that does have its benefits, but one of the downsides is de-skilling local teams. And we're trying to see how we can address that from the Panda point of view. And an idea that I think will be implemented over the year is having consultants in allied specialties, so peds, anesthetics, ICM and EM, having 1 or 2 PAs with Panda on the registrar rota, so they can maintain critical care skills and intubation skills as part of their job plan, but be on the Reg rota for Panda with PICU consultant support. So that will make the region more resilient, and teams will be able to hold the fort a lot longer till we get there. But I'm a big fan of trying to extubate locally, but there needs to be collaboration with the anesthetic side, because they will be giving the sleepy meds and they need to be the right sleepy meds.
So would you go back to Srini Teki Rao, and say, so this guidance sounds like a really interesting and valuable way forward, but it needs to be fleshed out with more detail about the process of what happens after RSI, particularly around earlier attempts at extubation, and of course, crucially, that question about whether retrieval follows rapid sequence induction.
I think we need to see what we need to audit these guidelines, because does it make more children to be sent over to PICUs than in the past? We need to look at that one factor. I doubt that would be, because I think the rapidity with which we are doing this likely to terminate diseases rather than most of the children ending up with intubations. So once it is intubated, it's completely a different ball game. Is it the comfort of the local anesthetist extubating and the local team extubating? So some people, some of the anesthetists, particularly adult anesthetists, wouldn't be comfortable at all extubating, and they said, no, I think you need to transfer out. But mostly now this, the transport teams are supporting locally, trying to give an extubation trial. That's I'm seeing more and more from CAT's team encouraging us to extubate locally. So I think there needs to be a little bit of culture shift. I'm sure that needs to take place over time.
But just to be clear, from your perspective, that suggestion that RSI should occur earlier comes with it an implied earlier attempt at extubation.
Implied, but I don't know how can we just influence local teams and their expertise?
Well, I mean, when I read it, wearing my Peterborough hat, I was thinking, well, that just means I'm going to be spending 12 hours on an adult ITU looking after an intubated patient, waiting for the retrieval team again. It sounds like that's not the intended consequence of the guidance.
Yeah.
Okay, Anna, you're working in Harlow. How do you what do you see happening after RSI?
So at the moment in Harlow, after an RSI, there would be, I would find it difficult to persuade, and again, this is about me being in my lane, a bit like Nick said, I would find it very difficult to persuade an anaesthetist to extubate a child at all once they've been intubated. But I reflect back to Costas, actually, that I also receive callbacks from many children that I send out within 12 to 24 hours that have been extubated in an intensive care. We still transport out with CATs, but with an intensive care in London. And they're being shipped back the next morning. So, I take what you say and I hear it, that we are intubating children to stop seizures, even on the current guidelines, and then very quickly they are extubatable and they're going to be sent back to us. So it does make me wonder, and I have worked in intensive care and in the CATS retrieval service. So I've been on both sides of this coin. I think I will find it very hard to persuade our anaesthetist to, in fact, I think I would find it impossible to persuade our anaesthetist to extubate currently without a national or regional guideline showing us that that's what we should do. But on the flip side of that coin, working for CATS, I have had many conversations with consultants across the North Thames region and into Essex, because when I was working for CATS, it extended all the way into Essex and Norfolk and Norwich, with children that fairly clearly were going to be extubatable within an intensive care unit. So I think that there needs to be more thought around. One, we don't know yet, do we? We don't know whether we're going to terminate these seizures earlier. So the RSI is then just a point at which we're going to have the seizure terminated at 25 minutes and we're ready, but we're not going to be RSIing these children. We don't know that. So I take Teki Rao's point there. We're trying to make things move faster. It might be that we stop all these seizures and the same number go to intensive care. We don't know. But if that is not the case, we are proposing intubating them earlier. And if we're saying lots of these children are extubatable, we need to have a feel for how that's going to happen in a local, because I just don't think that there's a capacity to transfer them all.
Agreed. Pooja, so we have got an intensive care unit. What should we do in Addenbrooke's?
I agree there's a lot of work that needs to be done to shift the culture, and I agree there's a role for regional work to look at this. I was also thinking about we probably need to shift a step further in the work that we currently do in terms of planning with families as well, and what they expect when they come to these points. So a lot of the response to the intubation and the drugs will depend on the individual child's etiology for seizures, their genetic background, etc. So we can plan ahead for some of that, and we can counsel families that this is what they may expect, that there may be a shortened period between the decision making around some of these things compared to previously. So that, I think, is an additional piece of work that needs to be done. And you're asking if we have the capacity for intensive care locally, whether we should move to earlier to adoption of these protocols. Absolutely. I mean, but that's easy for me to say as a neurologist. When I did your job as a pediatrician in Peterborough, I probably would have had a different answer.
Yeah, it does change things, doesn't it? Costas, do you think that, so if you're a Cambridge child and we want the very best outcomes for these children, should we have a lower threshold for a rapid sequence induction in Cambridge than perhaps you might do in Harlow or Norwich, bearing in mind the fact that we have an intensive care unit on our doorstep?
I mean, I think terminating the seizures of 30 minutes to 40 minutes doesn't really have a significant change in eventual outcome. What I would say is most children that fit the sort of criteria I just said, so not trauma, not focal, not abnormal CT, more than 6 months old, extubate within 2 to 3 hours, usually, from intubation, not from arrival to PICU. So the question, where should the child be looked after for those 2 to 3 hours, becomes easier to answer. So most DGHs will be happy to have that kid on propofol or Sevo post CT for 2 to 3 hours, stop the drug and see if the child's reaching out for the tube, and then the child has made that decision for you. If the child isn't reaching out for the tube after 2 to 3 hours, provided you've not given more opiates and benzos, then it's telling us to go in and retrieve. Because if they're needing more than 3 hours, it's unrealistic, unless their child is 15 or 16 years of age, that they will need to go to PICU. If they're 15 or 16, most DGHs would be reasonable to take to their own adult ITUs and extubate the next day. So those 2 to 3 hours to extubation are crucial. But 30 to 40 minutes, whether we intubate for better outcomes, because we can on Addenbrooke's, I think it's, you know, I don't quite see how it would have a significant long-term neurological change or a change in morbidity in those children.
Damien.
So yeah, just one tiny point, just to take on board what Costa said. There's a real potential here for inequity between patients, because I think there is a difference between the normal neurologically previously intact child who has a prolonged febrile convulsion and is in status, to a child with really complex needs who has chronic epilepsy and may have other features that make them a difficult airway. And what will happen actually is the child who has the more complex needs, and I'm generalizing here, I think is the one who would benefit from an earlier termination of their seizure, I suspect, because they're the ones who are having recurrent seizures and probably shouldn't be left to seize for a prolonged period of time. But hand on my heart, I know that happens to these patients because they seize all the time. And there is sometimes anxiety about the child who hasn't had the seizure before and people work a bit harder for. Now, I'm happy to be challenged on that, but that is my lived experience of the way some EDs and other hospitals operate. And the way we choose to do the RSI and for whom, I think is quite critical, because there is a real potential here that we will cherry pick the patients who are easier to do the RSI on and extubate, and that may disadvantage some children. It's just a thought.
Interesting. Good. Okay. So Pooja was encouraging us earlier on to have a think about some more data, for example, around the benzodiazepine interval. But it sounds like we possibly need a little bit more data and potentially a little bit more guidance around what happens after rapid sequence induction. If I can just put one quick question to the panel, and I think I'm going to start off with you, Kostas, because you may have more experience with this. Ketamine, thiopentone, propofol, all different potential induction agents for RSI. And the pediatric emergency departments will have lots of experience of use of ketamine when they're pulling arms and such and such. What do you think? Which agent should we use for rapid sequence?
I can tell you which one not to use and which one to use. So I think thiopentone should be, if not taken out of APLS altogether, should be come with an asterisk and the doses reduced, because you know, I've seen children go into cardiac arrest having been given 5 per kilo of thiopentone because they were fitting, and the problem is seizures are all labeled as seizures, and the truly sick status epilepticus that's actually septic and was getting a febrile seizure because of that, of which we've seen a few, get labeled as seizures, and then we because it's in the protocol, we stop thinking and we give them with something that's a potent vasodilator, and then they arrest. And I've seen in the last 2 years alone 3 of these children, and there isn't enough focus by the APLS guidelines as to the problems with thiopentone. Now, thiopentone is a very good anti-epileptic in a stable child with seizures. So, but the dose for induction is to be titrated and not be 3 to 5, which is a massive, massive dose. Ketamine, 1 milligram per kilo is a very safe dose. It has anti-epileptic properties. Sometimes you need to double it, and I would certainly advocate for that. And it's what most retrieval teams across the UK do. But you know, a word of caution of thiopentone: if your child is very hot, has a high lactate, don't reach out for the thio. And if you do, because that's what your anesthetist is comfortable with, that's fine, but don't give 3 to 5. You know, remember, shock is its own anesthetic. So 1 milligram per kilo of thio, if you have to use that, you can. Similar with propofol, is, you know, it will vasodilate. So I try and avoid it if I feel the child is more unstable than we think, and I titrate the dose down. But ketamine is usually a fail-safe, and it's the least cardio unstable induction agent that we have. I would add to that, since we're talking about intubation, if the child's fitting for a long time, we're going back to the rhabdomyolysis issue, they will get a hypokalemic surge with rhabdomyolysis. So succinylcholine, probably not the best paralytic agent to use. I would give rocuronium. So nice, 1 per kilo of ketamine, 1 per kilo of rock. It's easy to remember. It very, very rarely goes wrong. And that's what we do. One trick pony, but it works.
Interesting. Okay.
Share a couple of points, if you don't mind. Yeah, we had a child who was actually, you know, improperly managed and died during rapid sequence induction. The reasons were 2. Basically, child was having hypotension, which was not properly managed. On the top, they've given thiopentone, and child ended up with multiple inotropic agents. At the end, child died with significant brain damage. So there is a learning point for us. So I think I would take your point that clearly the thiopentone, we need to be really careful about that. 2 other points I want to make a note of is Keppra. While we are giving levetiracetam, giving 40 milligram per kg, no one has asked a question: what if someone is already on Keppra? Should we be using a less dose? I mean, to be honest, the panel discussed this. Even though Keppra, someone is on, the USA study adds up to 60 milligrams per kg is still safe. Therefore, without any confusion of changing the doses and all, like infinitone and phenobarbital, it's better we just give 40 milligram per kg with very, very safety margins. So Keppra, we don't need to worry about if someone is already on Keppra. The second thing is I just want to ask all units, particularly auditing our emergency status epilepticus. We audited only once in our unit before, and looking at it, even though those pre-existing guidelines have been in for many years, we don't follow them. Mostly the most reasons for being intubated is not quickly addressing the status by giving medications. Number two is giving a third dose of benzodiazepine. These are the two reasons, common reasons why children get intubated rather than actually the seizure or the underlying condition. So I think we should all units, again, with these new guidelines, we should re-audit and see and compare with the previous, if there are some audits done. That's my request for all units.
Always good to conclude with a challenge. From those outside the panel, any questions or comments on those points that we've discussed so far? Any questions for the panel? Anna.
I just wanted to make a final point about a potential secondary gain here, actually, is that I like the idea of ketamine coming in more consistently. I think pediatricians across the board will have more experience with this. And I think it can have a potential great benefit peripherally in our emergency departments, because emergency consultants, adult emergency consultants, regularly use ketamine to pull limbs and that sort of thing. In pediatrics, it's done, but much less frequently in DGHs. And I think if we get experience from this protocol of using ketamine and our anaesthetists get happier with using ketamine, we might be able to extrapolate this to more children and actually be able to use it more usefully for other things and have less fear about us being able to use a ketamine. So I think it potentially has a great benefit there, rather than having, so Costas is one-trick pony. If we actually start using it as a one-trick pony, people will be comfortable with it, and that will expand our experience of using it not only in this scenario, but then saying, actually, we're going to have to do a trauma transfer for a limb that's falling off. That we can pull that. We'll pull it with ketamine. We've got a pediatric consultant. We've used it in epilepsy. We know it works. We're going to do that, and it's much more comfortable for us. So I think that there is potential secondary gains to the ketamine.
My nephew had his arm pulled with ketamine, and I was talking about this at the dining room table, and my teenage daughter said, "What? They gave Milo Ket?" Which I thought sounded a bit practiced, like perhaps she had more experience and expertise in that area than I was hoping for, but still. Thank you very much, everyone. I think the panel has laid bare the potential benefits and also some of the potential pitfalls of the changes to the guidance, and I think that's given us all some food for thought. So thank you so much, panel.
That was fantastic. Thank you so much. Next time, I'm going to schedule 2 hours for this kind of a discussion. It was brilliant, and I think we could have carried on so many other questions that I think we potentially could have touched upon. Thank you very much to everybody, the panel. Richard, thank you so much for putting together such a great discussion. Thanks everyone for joining. There is a feedback link in the chat if you just scroll up a little bit further. So please do fill in feedback. And for those centres in the east of England, we do rely on various centres to sign up. And I know that you have very kindly volunteered for in a couple of months' time, and so we have got a programme. But for August and September, we're looking for centres to provide some children's emergency medicine teaching. So if you feel inclined, then please do let us know. Okay, well, thank you very much, everybody. Enjoy the rest of your mornings. For those of you that are part of the committee or trust reps or interested in the sort of business side of running PEMEast, please stay on and we'll continue with our meeting.